Okay. Thank you, Aditya. Good evening, everybody, and dear students. Today is our live session after 3 weeks. For this session, first of all, I'll welcome Professor Manoharan Sir from Mayakula Medical College, very senior surgeon, as well my good friend and sir. I learned a lot from sir. And Professor Sunil Joshi, at head of the department from Chikmagalur Medical College. Sir, welcome you very much. Thank you very much for making your time. And Professor Robin, my very dear friend from Pushpagiri Medical College. Robin, I welcome you. Thank you very much for joining
Good evening,
and being always part of
sir.
my sessions. And I welcome Apurva Ranjan and Shubham, both of my students from Kasturba Medical College, Mangalore, final year students. They are presenting. I welcome all students who are joining or joined through YouTube channels. And without wasting much time, we'll straight away go on with the presentation. I think who is presenting Apurva?
So I'll
Sir,
present the.
Okay, we'll go on to the presentation. Aditya, Sukhel, PPT, connect the PPT, Aditya. Start, Apurva.
sir, Shubham will start with the history and I'll be doing the examination.
One minute, Apurva. Sir, Sunil Joshi, sir, let them finish the history, then we'll have discussion about detailed history. Okay.
So, with your permission, may I start?
Yes. Okay, Shubham.
So starting off with patient particulars, a 56-year-old gentleman hailing from Shimoga, farmer by occupation, came to Government Venlock Hospital on 2nd April 2025 with the chief complaints of next slide, please.
Sukhel, next slide.
So, will the previous slide, chief complaints?
Sukhel, previous slide, second slide.
Shubham, are you presenting from your laptop?
Yes, sir, I'm presenting from my laptop.
I think then you can change it. Huh? You can slides.
Sir, I'm not able to change the slides.
Oh, okay. Fine.
To clarify with the okay, now it is Shubhan. Sorry, go ahead.
I'll continue from chief complaint, sir. A 56-year-old gentleman hailing from Shimoga, farmer by occupation, came to Government Venlock Hospital on 2nd April 2025 with the chief complaints of pigmented lesion on the sole of the right foot since 2 years and pain over the lesion since 3 months. Coming on to the history of presenting illness.
Next slide.
Next slide, please.
Sukhil, next slide.
Coming on to the history of presenting illness, the patient was apparently well 2 years back until he noticed a blackish pigmented lesion on the sole of the right foot, pinpoint in size at the time of onset. For the last 1 year, the pigmented lesion is growing rapidly to the current size involving the sole. There is history of darkening in color of the lesion for 3 months. There is history of ulceration over the lesion for 3 months, which is insidious in onset, progressive in nature, and is not associated with any kind of bleeding or discharge. There is history of dull leaking pain over the lesion, which is intermittent, non-radiating type, and aggravates while walking or prolonged standing, but relieves on rest. This complaint is over 3 months. Next slide, please.
Aditya, next slide.
There is no history of bleeding or discharge. There is no history of itching. There is no history of any other nodules, swelling, or pigmented lesions in the limb or any other parts of the body. There is no history of cough, breathlessness. There is no history of mass abdomen. There is no history of loss of weight or loss of appetite. Coming on to the past history. Next slide, please. There is history of previous admission 1 year back for the similar complaints. There is no history of similar illness in the past. There is no history of diabetes, mellitus, hypertension, asthma, and there is no history of previous surgeries done. Next slide, please. Coming on to the personal history, the patient consumes predominantly non-vegetarian diet, reports with adequate sleep, the bowel and bladder habits are regular. There is history of smoking for 17 years. There is no history of alcohol consumption. Coming on to the family history, we display a pedigree chart of the patient for 3 generations. There is no significant family history of similar lesions or any kind of skin tumors in the family. Next slide, please. To summarize the history, our 56-year-old gentleman complains of pigmented lesion on the sole of the right foot for last 2 years and pain at the site of lesion since 3 months. The lesion was pinpoint in size at the onset and has been growing rapidly since 1 year to the current size. The lesion has darkened in color since 3 months. There is ulceration over the lesion since 3 months, which is progressive in nature. Patient also complains of pain over the lesion, which is dull leaking type, intermittent, and there are no symptoms suggestive of distant metastasis.
Sir, we'll go back to the first slide. Okay. Go back to the first slide, Sohail. Next slide. Chief complaint, third slide. Okay. Sir, Manoharan Sir and Robin Sir.
Yes, sir.
Pigmented lesion, he has told, pain over the lesion for 3 months.
Rapidly.
Yeah. Whether he has mentioned lesion is progressively increasing size or not?
The next slide, yes. Next slide is mentioned. Rapidly increasing.
Registration.
Next slide.
Next slide.
Yeah.
He said 2 years back, noticed blackish pigmentation, then it is growing rapidly to current side involving the soul. Darkening color of the lesion for 3 months.
Ulceration.
Ulceration, discharge, everything. Dull aching pain over the lesion, intermittent, non-radiating. What is that non-radiating means? What exactly you will expect, Shubham? Why?
So to the patient, we had asked for any kind of radiation to the other parts of the limb or to the thigh or towards the inguinal region, to the groin.
Is it very common from sole to thigh to inguinal region?
Uh,
An ulcerative lesion that can have a dull aching pain over the lesion, and does it radiate to those places?
so not with the similar complaints, but in case there is prolonged standing or there is a prolonged walking for some time.
So no,
But
is
this
it
kind of
relevant to this case?
Is
If
it
you have
common
pain
like
over,
that?
yeah, is it? It's over the lesion.
No,
Okay,
sir.
we
So
agree.
not relevant with the current chief complaints of the patient.
not applicable to this case. No.
Would not applicable to this case.
What
Like
is the
Right,
suppose,
sir.
cause?
for
Yeah.
instance, you have a right groin to loin to groin pain. You have periumbilical to somewhere radiating to RIF. You have something from right hypochondrium to radiating to right shoulder. That is some radiation. यहाँ पे तो that is not happening, na? Yeah.
Right, sir.
What is the cause for dull aching pain, Shubham?
So dull aching pain.
Do you think? Just to predict why he's having pain. Initially, it was painless. You said, then it has become
Yes.
dull aching pain.
What
What
is
is
it?
So
What is it?
due to involvement of the deeper tissues or the depth of the lesion would have increased
okay?
over the time.
Possible. Okay.
There could have been any invasion to the nerves, any kind of perineural invasion can be suspected from this complaint.
Okay. Agreed. Agreed. Why darkening in color in 3 months? What it suggests for you?
So darkening in color could be just progression of the chief complaints, what he has mentioned that there's a pigmented lesion since 2 years. And since sometime he says there is darkening, so this could be just progression of the complaint.
Okay. Okay. Anything to comment on that, Robin, or sufficient?
Initially, you said it is pinhole size.
Okay.
Initial size is like a pin, no? Shubham,
Shubham,
what was the initial size? Am I
increase-
audible?
Shubham is frozen.
Shubham, you understood now what sir is asking?
Shubham, am I audible?
Hello.
Am I audible?
Shubham, you can hear.
Can you hear me?
So
Can you
yes,
hear?
sir, I can hear you now. Yes, sir, I can hear you now.
You can hear you, sir, but
Initial lesion was pin size, you said. Pin size, initial size of the lesion.
Yes, so initial size was
What was the size? Initial size. Now you said it is now. History-wise, patient noticed the lesion in the sole of the foot. As per history. Yes or no?
so I'm sorry I missed your question, so some network.
Initial lesion is in the sole of the foot.
Right, sir.
The patient says he noticed the lesion in the sole of the foot of such pinhole size.
we visit whether it is
No, history-wise, melanoma, unless the lesion is big, or it is discharging, or producing symptoms, or satellite lesion or something, usually, unless it comes to a significant range, the patient will not notice. Usually the presentation, they come with inguinal load, they come with
this is here. This he has noticed whether he had itching, whether it is bleeding from the site.
No, sir, there is no history of any kind of itching or bleeding or anything, any discharge from the side.
Negative history has given.
Well, okay.
Proceed.
Actually, he has noticed it 2 years back only, is it?
Yes, sir. He noticed 2 years back. He got a biopsy for the lesion 1 year back, but he lost follow-up after the biopsy results came.
Okay. But he was probably somebody diagnosed it, thought of, but he didn't go for follow-up or further treatment that point of time, I think.
Okay.
Right, sir.
Proceed.
Okay, next slide. Okay. Robin, Sunil Joshi sir, are you there in the line?
Yes, Shubham,
Robin.
you've given us all the points. Just for the listeners, you have two criteria for malignant melanoma. Which are those criteria that you have followed here? Could you please tell us? This is for the checklist of history taking.
So as in the criteria is for measure for intensity of the size and the depth of the lesion, sir.
Yeah.
So we follow the Breslow's criteria and
No,
the
I mean the Clark's levels of invasion of breast loss. I mean in history, the change in color and all those things. A, B, C, D,
A, B,
E.
C, D, E. So the distinct features of A, B, C, D, E, which is A standing for asymmetry of the lesion,
Asymmetry
B
of the
stand
lesion. So some difference in the shape of the lesion, initial to now. Agreed. So we just want to cover it so that gone so well. Yeah. Okay. B.
So B, we define for the irregular borders of the lesion,
Okay.
while C for the color of the lesion, any
Color
kind of
change.
hyperpigmentation or color
Change in color.
changes,
Yes.
and
Which,
then
just for the sake
D.
of completion, there is pigmentation necessary for diagnosis of malignant melanoma?
No, sir. Since there are amelanotic melanomas also, so
Yes, same,
pigmented
same. So
melanomas
that
are not
means
a
around 2 to
diagnostic.
3% maximum. That's all. They're very aggressive, but pigmentation is not necessary for the diagnosis of malignant melanoma. It's very good. D,
So D is for the depth of the lesion.
depth of the lesion.
So if there is more than 6 millimeter depth of the lesion, we consider it to be malignant melanoma.
Okay. E,
E stands for evolution. Evolution could be in the terms of size, shape, or color of the lesion. So
right. Yes,
E would
very
stand
good.
for
So
evolution.
this is one criteria that we usually follow from time immemorial. What is the other criteria that we have?
So other criteria, Glasgow criteria.
Yes, it's called the Glasgow 7-pointer. Yes. You have how
Yes.
many majors and how many minors?
So three major and four minor criteria,
Yes.
where
Yes,
three
very
more
good.
than three score of more than three stands for significant or progression of the malignant melanoma.
Okay. Right. So you have covered all those points there. And no history of cough, breathlessness, mass per abdomen, loss of weight, loss of appetite. I We assume that you are trying to rule out the metastasis.
Yes, sir. With all these complaints and all these questions, we're trying to rule out any hematogenous spread or any distant metastasis.
Secondary.
Which are the common sites of metastasis in melanoma?
So most commonly it is liver, lung, and brain. While
Liver, lung.
with liver it presents with massive hepatomegaly, and lung could be cannonball
X-ray.
appearance or
X-ray.
cannonball metastasis,
Okay.
hemoptysis or cough. Yes.
Right. Yes. Very good. What about the eye?
So ocular melanoma, while it does not involve any kind of lymphatic spread because there are no lymphatics for the around the ocular site, while it originates from the iris, retina, choroid, ciliary body. These are the sites for origin of ocular melanoma. Yeah.
Okay. So yes, they've covered all the points. Don't services, sir. Your audio is off. And Shubham, please don't forget the mucocutaneous junction, sir.
Sorry, sir.
Loss of
Mucocutaneous junction, MC junctions. Mucocutaneous.
Right, sir.
Yeah.
loss of weight, loss of weight.
So loss of weight to rule out.
No. What?
I don't routine malignant cachexia may not be applicable here in this case.
It's a metastatic disease. Suggests metastatic disease.
Right, sir.
Yeah. Next slide. We'll go to next slide, Robin. Next slide.
Yes, sir.
Okay. 1 year back. But no biopsy they have done. No, you have not mentioned that.
Admission 1 year back, what happened?
Previous admission.
So,
You said similar complaints.
Similar complaints, what happened? Any details?
sir, with the previous admission, the patient got biopsy. A biopsy was done for the patient where the diagnosis of malignant melanoma was done. But the patient lost the follow-up due to some conditions in his family.
Shubham, have you asked what type of biopsy they have taken? They have taken it entirely. What was the size of the lesion at that point of time? Have you asked in detail? Because that is very important.
So the patient says the lesion was pinpoint in size, not a bigger lesion.
Okay.
So a wide excision biopsy would have probably been done for this patient.
Oh, they might have done the excision. Okay. But he didn't go for follow-up.
Yes, sir. The patient lost in follow-up.
Yes, remote. Have you asked that detail?
Sorry, sir.
Have you asked
The details.
Yes, sir. We've asked the details for the biopsy and for the admission 1 year back.
Okay. No other thing, no history of previous surgery, but excision biopsy was then. That is, you said okay. Next slide. Okay, personal history. No significant family history. Means, is it important family history in this patient?
So, since there are familial melanomas also, or there could be any kind of conditions which can be associated with risk factors like xeroderma pigmentosum or other familial conditions. So, to rule out those conditions, we've asked the patient if there are any skin lesions or skin malignancies in the family.
Okay. Right. What are some? Can you mention some familial conditions? Just for may not be able to remember many times, but still.
So one of them could be xeroderma pigmentosum.
Okay.
And other could be familial melanoma nevi.
Okay, there are few syndromes also. You can always refer.
Yes.
Just remember, family at least in 10 to 20% of individual. That's why detailed family history with the 3 generations is important. You have put the chart. That's important. Okay. So
Right, sir.
next slide. Okay, summary. Pigmented lesion, 3 months, pinpoint in size. That was operated when it was pinpoint in size. You have not mentioned that. We could have been, if we has gone for follow-up at that point of time, for a proper wide local excision and further treatment, it would not have recurred. But he didn't go that point of time. That's an important point which you have to remember.
Right, sir.
Was there any complaint in the inguinal region?
So nothing mentioned by the patient for any complaints in the inguinal region or any sort of that complaints.
Okay. Next slide. Okay.
So I'll be continuing with the examination part. So general physical examination. Patient was conscious, cooperative, and well oriented to time, place, and person. He is well built and adequately nourished. His weight is 62 kgs. Height is 1.76 meters. That makes his BMI 20 kg per meter square, which is normal according to WHO classification. Coming to the vital signs, patient was afebrile at the moment of examination. His blood pressure is 110 by 70 mmHg, which was taken on the right hand. Respiratory rate is 16 cycles per minute, and the pulse was 76 beats per minute. Regular rhythm, normal volume, normal character. There was no radial delay, and other peripheral pulses were normal and present bilaterally. Next slide, please. So pallor, ictus, cyanosis, clubbing, lymphadenopathy, and pedal edema were absent. Next slide. Coming to the local examination, next slide. So on inspection, we see a blackish ulceroproliferative lesion, which is present on the plantar aspect of right foot. So it's solitary in number and measuring 2 into 2 centimeters. It has a spherical shape with regular borders and a well-defined margin. It extends 6 centimeter from the heel and 12 centimeters from the base of the great toe and 8 centimeters from the middle malleolus. It has a rough surface and the surrounding area is hyperpigmented, but there is no erythema seen. There is also no induration seen. And the lymph node examination, the surface over the inguinal lymph nodes, they appeared irregular, both left and right side. Next slide. So coming to palpation, there was no local rise of temperature. Tenderness was present while pressing on the lesion. All inspectory findings were confirmed. That is a solitary lesion, 2 into 2 in size, present on the plantar aspect of right foot. It is spherical in shape with rough surface, regular borders and well-defined margin, extending 6 centimeters from the heel and 8 centimeters from the middle malleolus. The surrounding skin was hyperpigmented, but there was no pain. Next slide, please. Periphery arteries were felt. Lymph node examination, both the horizontal and vertical group of inguinal lymph nodes were palpable. They were discrete, enlarged around 2 into 2 centimeters, and they were mobile and firm in consistency. Next slide. Coming to the systemic examination, next slide. Respiratory system, normal vesicular breath sounds were heard. Cardiovascular system, S1, S2 was heard, and there were no murmurs present. Gastrointestinal system, it was soft, non-tender, and there was no organomegaly. Central nervous system, no focal neurological deficit. Next slide. So coming to the summary of the entire case, a 56-year-old male hailing from Shimoga complains of black ulceroproliferative lesion on the sole of the right foot for the last 2 years and pain at the site of the lesion since 3 months. The lesion has increased in size and is currently measuring 2 into 2 centimeters. It has progressively darkened in color and ulceration can also be seen. Patient complains of pain over the lesion, which is dilating type and intermittent. There is no history suggestive of metastasis through cough, breathlessness, abdominal mass. Next slide, please. Yeah, on examination, a solitary lesion 2 into 2 centimeters in size was present on the plantar aspect of right foot. It's spherical in shape with rough surface, regular borders, and a well-defined margin, extending 6 centimeters from the heel and 8 centimeters from the middle malleolus. Tenderness was present when we pressed on the lesion. Surrounding area was hyperpigmented and discrete enlarged inguinal lymph nodes measuring 2 into 2 centimeter were palpable, which were firm in consistency. Next slide. So, based on the history and examination, the diagnosis is a 56-year-old with a blackish ulceroproliferative lesion on the plantar aspect of right foot, which is suggested of malignant melanoma, stage T4B N1 M0.
Okay, wait. We'll go for the finding. Go back to the examination slide. Still back. Inspection. Okay, inspection. Okay. Sir, Robin Manoharan Sir, because he said a lesion you can see, sir, that it is a medial malleolus. They have told she has told 8 centimeter. I don't know whether it is. I know you have measured. Have you measured the lesion?
Yes, sir.
Is it a swelling or ulcer?
Sorry, sir?
Is it a swelling or ulcer?
Sir, it's a ulcer. It's not a swelling.
It's not a swelling. But why you have put it as a lesion?
Sir, because
I'm just asking because it is difficult to many times interpret these things. But still, sir, Manohar, sir, Robin, how exactly to express these things?
Heading you put blackish ulceroproliferative lesion.
Blackish ulceroproliferative lesion she has written.
That's the heading. So you call it as ulcer or you call it as a swelling?
Yeah, swelling.
So given the title. Yes,
sorry.
You have told the ulceroproliferative lesion already you have written there. Then natural that means you agreed that it is ulcer.
Sir, the reason why I did.
I hope you got the point.
Yes, sir.
Yeah, so you already mentioned ulcer. So why do you want to say lesion? Na?
Yes, sir. Yes, sir.
Yeah, there is one start of that way. Na?
Okay, sir.
Yeah, A single ulcer of size approximately 202 centimeters, extending 6 centimeters from the heel, 12 centimeters from base of toe, 8 centimeters from
Okay, sir.
malleolus on the plantar aspect of the right foot.
Okay.
Have you measured the lesion and this lesion surrounding area is hyperpigmented? How far it is hyperpigmented?
Sir, only around like 0.5 centimeters it was hyperpigmented,
Not
not
beyond.
more.
You are interested if there is hyperpigmented patch just beyond the margin, what it is called as?
Sorry, sir.
If there are multiple hyperpigmented patches little away from the margin, what it is called as?
Satellite nodules, sir.
Right nodules. Okay. Surface core satellite. That's what, because
Actually,
you are
actually the picture, sir. Actually the picture. What are the hypopigmented areas above the lesion?
yeah. Hypopigmented. If it is hypopigmented, what it means for? That's what sir is asking.
Yes, suppose tell me the lesion is there. Above that, there are circles.
There are few hypopigmented patches are there.
Patches are there. What are they? Previous biopsy site or something else?
So whether it's related to this or not related, are you really considering it as significant? If it is significant, then it is rather wider. Your dimension, what you are told, has to be changed now.
Just above the lesion, you see that
Yeah,
whitish.
just distal to that, you can see that if hyperpigmented patch. Have you given importance to that, or you thought it is normal, or it is have you asked whether that patch is similar time it started? It was there earlier.
No, sir. Actually, the feet was dirty, so that's why it appears like that.
Specifying.
Sir?
You understood, no, what Professor Manoharan Sir is specifying?
Yes, sir. Yes, sir.
So, because you have to, this
What
observation is very
are
important.
the previous biopsy site, madam? Same site biopsy was done or some?
Could you make out the biopsy site? Sir, Sunil Joshi, sir, you can ask questions, sir. I know.
Yes, sir. Certainly, sir. Sorry, I was in a kind of middle of something. So no problem. I'm listening as well.
Yes,
So
sir.
is that a pigmented area? We are talking about satellite lesions there. But is it possible that it is the normal sole skin and there are depigmented areas? Why not look at the other end of other side of it?
Yeah, that's
Or
what.
maybe some chemical application or the dressings that he does?
Yes, sir. I thought that it's that as well as he was walking barefoot, so I thought it was dirt on his sole. That's why I did not specify it as hyperpigmented lesions.
Okay, so
Once you observe, you should have asked whether it's a recent onset, it was there earlier, whether it is related to this. That makes a lot of difference. That I think that's what both Manoharan Sir and Sunil Joshi sir they were actually pointing that. Understood?
Yes, sir.
So inspection of sole is very, very important in surrounding areas. Very carefully you have to observe what they're highlighting.
Were you able to identify the excision scar, doctor?
That's what you could have you looked for the scar. He said previous surgery.
Excision biopsy done.
No, sir, we were not able to make out any scar.
What is the reason for that? It is not visible.
So there was ulceration, so we could not make out a lot.
In that because it's gone beyond the scar.
Yes, sir.
Now outgrown the scar area.
Scar.
Probably scar is also below the lesion, the existing lesion.
Yes.
Possible. Yes. Okay.
You put next slide, sir. Robin. Sunil will okay. Next slide back. Yes. Okay. Okay. Palpation, tenderness we have discussed, pain we have discussed, tenderness, Shubham has told. What it implies to you? Tenderness.
Sorry, sir?
Tenderness.
Tenderness is there. I'm pressing.
Yes, sir, but it was only present when we pressed the lesion. If I just touched it, it did not, it wasn't painful to him. So I had to really press on it for him to tell me that it was paining.
You are written spherical in shape. So you said it is ulcer, it's spherical in shape. You said it's a lesion. Spherical is more towards the swelling.
Okay, sir.
Okay, so There is always confusion, sir. Sunil Joshi, I think, Robin, somebody can always express what exactly they should tell. Because such lesions, they were always, students were always confused whether they should tell swelling, ulcer, or then they put it as a lesion.
Apurva, I will go back to your heading. Apurva, that was the heading you have given. So remember, ulcer, what is the definition of ulcer?
Sir, it's the when there is disruption of the epithelium lining.
Of the skin. So there is a
Yes,
growth
sir.
which is coming through the opening, what do you call it?
So that's a swelling.
Huh? Through the
Sorry,
opening.
sir, I could not hear.
Through the ulcer, if a growth is coming out, what do you call that?
That's a ulceroproliferative lesion.
Fungation.
Fungation. Okay, sir.
Lesion,
It is not classical, but we can say that melanoma is now breach the skin and
I
probably
think,
it looks like that.
Sunil, you can highlight this. I think this lesion, they can tell it as an ulcer, I think, because sometimes we got a nodular melanoma, and they will find difficult to express.
Yes.
This, all those things. So,
So I would present it as an ulcer probably, like she's done.
I know.
And yes, it is quite interesting that it can get into different differential diagnosis. It doesn't seem to be a pretty straightforward melanoma as we thought. It can have differential diagnosis. Like we'll discuss that. I'll ask a question.
That we'll discuss because they will go for the already they
They
present
want to go for differential diagnosis.
thing. Okay.
Yeah.
Next slide. Robin will go to next slide. Okay.
Yes, yes.
So lymph nodes, she has mentioned horizontal, vertical, both groups. Of course, it's visible there, and palpation. Is it there? How many lymph nodes were there?
Sir, the horizontal, I was able to palpate like 2 discrete, and on the inferior also, I was able to palpate 2 to 3
Okay.
lymph nodes.
Okay. So,
So which ones do you expect to get enlarged in this lesion?
which one is it?
The horizontal or the vertical group?
What is more relevant for you, vertical or horizontal? Just to
Sir, the vertical,
not eventually. There's a different thing.
sir, the vertical group usually drains the entire limb, so that should be enlarged.
Okay, but opposite side also you can see some lymph node actually on inspection.
Yes, sir.
This is also palpably set. Okay, we'll go to next slide. Okay, next. Anything to ask about this? Because why you want to check all these things? Liver, no organomegaly you wrote. Which organ you are interested?
Sir, I wanted to check for hepatomegaly because if it has metastatized to the liver, then there would be ascites or hepatomegaly seen. So,
What's the speciality of liver involvement in melanoma? Any specifications? It attains very large size, massive hepatomegaly.
Massive hepatomegaly, yes.
Okay. Massive hepatomegaly it is one of the causes for massive hepatomegaly is melanoma causing secondary in the liver. Okay. So other things she has mentioned, all this is all for metastatic workup, clinical workup, metastatic workup she has mentioned. We'll go to next slide.
Abdomen you can comment, there is no mass. Usually, as per class, it says from inguinal node to abdomen mass, from abdomen mass to got back. The old books you can see a diagram. Abdomen mass right there. Like the dotted lines they would have shown it. Abdomen mass is one of the percentages after inguinal. These are all other things are what you are talking about is metastatic. Like lung problems, other things come to later stage. Okay. Then supraclavicular also is mentioned.
So, sir, Manoharan sir, what they should mention as ulceroproliferative lesion or it is a pigmented ulcer if they mention sufficient. Whether it is feasible here or not, I'm not sure.
Picture is not very clear. We could have got a reason closer. Probably
Yes.
we would have given a
They
better.
would have just mentioned a pigmented ulcer, I think.
Laceration is ideal.
Probably.
Safe one.
Okay, right. There is a difficult to many times clinical aspects. I agree with that. Okay.
Because the ulcer shape is well rounded, circumscribed. That's why that's also ulceroproliferative.
That's what Professor Sunil Joshi told. There is not this looks lot of different looks differently than the melanoma. That's also true. So next slide. So there's the same thing she has mentioned, whatever that they put in a detail actually. Summary they put again examination. I think last time we have Robin has discussed, we can make it little briefer as far as summary is concerned. Again, don't require to repeat everything, but briefly you tell when you put the but summary is a must. Summary for history, summary for after examination is a must, but to make it little briefer. Okay, that's the only thing. So next slide. So that's what they said that they put some differential diagnosis. Sunil, you can take over and
Yes, sir.
with you and
So I think at the end of the clinical examination, all this, we should be able to, based on history, it's a 2 years history, which is quite long for it to be a benign lesion. However, we can justify that it probably got into a malignant transformation, explain that. But can it be much simpler than that? Can it be a trophic ulcer? It's sitting on the heel. It looks round, spherical, as you said, spherical or circular. And is it possible that it's got edges which look like this punched out? You know, typical of it looks like a neuropathic ulcer. Or if I say it is an ischemic ulcer with a necrotic patch in the base of the ulcer, how would you justify?
ischemic
Because
ulcer.
all the differential diagnoses seem to be in the direction of either a BCC or compound universal squamous cell. Why can't it be anything simpler than that?
Right. Apurva, Shubham, you can also answer now. Now we are going for a discussion. So
This is a biased diagnosis, I would say.
So, sir, you said neuropathic ulcer, so there should be a change in the status of sensation. So there is no loss of sensation.
Okay.
So that, and if there is no history of varicose veins or dilated veins in the limb, so venous ulcer is also not there, and distal.
No, this is not the site for venous ulcer. Never mind. Never think about that.
arterial venous ulcer won't come into the picture here.
Yes, sir.
Arterial disease, you are arterial. Sir has asked about the arterial disease.
Ulcer with a necrotic patch.
Yes, sir. So arterial disease, to rule out arterial disease, all the peripheral pulsations, they were felt.
First history. History, dear. First history.
History, there is the pain is there, but it's not as intense.
So
what
kind
we
of pain
can.
you get in vascular pain?
So you are told.
So there would.
Because you know that they presented this patient said it is a pigmented lesion to begin with.
So if it is an arterial ulcer, then there would be a cramp-like pain, which could be seen. But here it's a dilating pain, and that too it aggravates on prolonged standing. But while most of the time it's not there and it's intermittent, so I think we can rule out arterial disease based on this.
What is that pain called as?
What, sir?
The cramp-like pain. Can you describe it more?
Claudication.
Sir, claudication.
Yes,
Claudication pain.
Right. Okay.
I think Robin, you can just Robin.
Sir, I'm just typing in the YouTube all the points. So it's okay. Sunil sir is there, so yeah.
Okay. Right. This here it is presented with the pigmented lesion. Melanoma should be considered. It's right. But you said pigmented BCC. Why are it pigmented BCC?
Apurva,
Sir, because
is it a very
pigmented-
common site for what is the common site for
BCC.
So for BCC, the most common site is the face. That's why it's also known as tear tumor, because it's usually in the cheek and the ear, eye region. So that is the most common site for BCC.
And then why did you keep it here? Why did you put it here?
Here, it can occur in the leg, the proximal part. Proximal leg, it can occur rarely, but here it is not common. Pigmented
Yes, sir.
carcinoma, epithelium is okay. It definitely accepted.
Yes.
Okay,
Okay.
but pigmented BCC you put as a part.
Now that security instruction had come here, then I just told him that I come from.
Apurva, you have mentioned compound nevus.
Yes, sir.
Why you have gone from the malignancy is totally again benign condition? What is compound nevus?
Sir, compound nevus is basically when we have junctional nevus, which is arising from the basal layer, as well as dermal
Intradermal.
nevus. Yeah,
Intradermal.
infradermal is also present. So, junctional nevus is a pre-malignant condition, and it has a high potential of turning into a malignancy. So that is why I included it in the differential diagnosis.
Okay, right. Shubham,
अब सब लोग
Shubham, why you written
इससे
T4B?
बाहर जाने तक हम लोग के आप उधर से आए हो.
Why you written T4B, Shubham?
Sir, T4, particularly since the lesion extending, the tumorous lesion is extending more than 4 millimeters. So that is why T4B.
T4B. Okay. Okay. Size is important, and ulceration, if it is there, it becomes
B, then it becomes B.
Okay.
Yes.
Okay. So anything else to add for the different diagnosis to this? Do you think of? As Sunil Joshi sir told, this one trophic ulcer is less likely because we've got a pigmented history. You have to think of widely, but not venous ulcer. Venous ulcer will not occur here.
Yes, sir.
And arterial ulcers are usually in the lower leg around the ankle, not in the sole. Not in the sole. So these peripheral pulses are well felt. So will it be sarcoma? Any type of sarcoma, dermatofibrosarcoma, all those things. Do you think of such things?
Sir, firstly, the pigmentation is not usually present in those kind of.
Fibrosarcoma pigmentation can be there.
Yes, sir. In that one, it can be there. But
What is the common site? Fibrosarcoma. It is a common site.
sir, it's
It could be
the
on the
trunk
chest
area.
wall.
Chest wall, abdomen, back in this area is a common site. So when you write a differential diagnosis, what Robin and Sunil there, just Professor Sunil is telling is, you have to think whether it is feasible to that anatomical site and for that findings. Understood?
Okay.
When you write this, we are not denying, but the pigmented means it is very less likely to happen in the soul. So not a common site at all. Squamous cell carcinoma with the pigmentation can occur. Compound nevus, unless you think it is not. You said rapid increase in size, irregular surface. You said pain is present. Such situation again, again you have to whether it is right to think or not. Any other possibility to let them that they should think of Robin, Sunil? This is I think this is the Sir Manoharan Sir would be okay. I think if they say these things, but some difference will be thought of. They should be able to give the answer why it is not. What is the reason? What is the clinical justification for not consider this thing? If they consider pigmented disease, it's quite difficult to answer because it's a very rare site. But epithelioma is definitely a site which occurs here. So, will you consider it as a recurrent melanoma because previously operated, or disease which is not cleared properly, only biopsy diode? I'm just asking.
No, I would say recurrence only if it has been completely removed and then we find a new one. Recurrence is only when it is completely removed and then comes back.
So it's not possible because unless they are removed entirely and then recurred, otherwise we can't call it as a recurrent. They have done the biopsy, but further things are not happened because
when it was a biopsy, probably it was an incomplete procedure, isn't it? It's only a biopsy that they have done.
So probably the depth was inadequate.
Yeah, they have done the excision biopsy, but he didn't go for follow-up afterwards.
Proper margin clearance would have.
Yes, it needs to be completed. Once you have established the diagnosis, it needs to be revisited, and our treatment is only by local excision, not the excision of the lesion.
Did not come for that. So go to the next slide.
Yes, sir.
So continue, Apurva.
Yes, sir. So coming to the investigations, firstly, we'll go for an excisional biopsy. Then we can go for a FNAC of the lymph node, CT scan for the chest and abdomen. Then we can also consider PET CT or sentinel lymph node biopsy. And we can also check the tumor markers in this case.
Which markers?
Tumor markers, sir. So there is one HMB45, which is human melanoma black 45. which is a monoclonal antibody which is specific for.
What's commonly done? What is easily, freely available in most of the centers?
Sir, LHD is there, then Melon AS100, these are there.
LDH is commonly done. LDH is
Yes, sir.
done in most of the places.
Dr. Apurva will go by one, I feel.
Yes, sir. Yes,
Yes.
sir. Better, sir.
The excisional biopsy, can you elaborate on it?
Sir, since we are considering.
Your case is melanoma, malignant melanoma. When you say excisional biopsy, just for the sake of your colleagues who are listening. Yes.
Sir, the reason why we go for excisional biopsy and not incisional is because melanoma can spread.
What type of excisional biopsy?
Sir, punch biopsy we'll go for because we'll.
You say three-dimensional margin-free clearance. That is basic mandate.
But currently, many books mention punch biopsy, but that is not a very large one, very large melanoma. Not wherever possible excision biopsy.
Margin-free clearance. That can have all dimensions you mistake. Now you want to check the margin-free. How you will check it while taking biopsy?
Sorry, sir.
How will you check that it is margin-free? At the time
Sir,
of taking biopsy, how will you ensure that it is margin-free?
Sir, by trying to stick to the center.
No, you can't stick to the center.
Center, if you go to the center, you have a failure. Center is all dirty necrous tissue.
The question is very simple. How will you check if
it is margin free?
Yeah.
Just now, sir said no. If you do inadequate excision, definitely that will be recurrence.
So by taking the normal appearing skin as well, beyond at least 3 millimeters or more than that from the pigmented ulcer in this case.
Millimeters won't work. I want proof that margins are free. So you ask the
So frozen section.
Frozen section, excellent.
The
pathologist that you send it and you just check the margins. And
ideally, frozen section and make it.
That is the best thing to do, safest thing to do. Yeah, keep the frozen section facility available.
Yes, sir.
Then the biopsy, say whichever margin is positive, you have to go for a revision.
Shubham, what about incision biopsy?
So incision biopsy to avoid any kind of hematogenous spread or disrupting the lesion to the depth. And yes, sir, just to avoid any kind of metastasis or hematogenous spread.
Do incision biopsy in melanoma unless it already when they present with the stage 4 disease with metastasis. Then it is okay. Otherwise, remember as undergraduate, by principle, no incision biopsy for melanoma. Straightforward. It is excision biopsy, of course, margin-free excision biopsy. Very clear concept. There are few books mentioned punch biopsy, again very large lesion. Otherwise, ideal is incision biopsy. At your level, ideal is incision biopsy. Don't get confused. Okay, it's a very, very clear concept. I think, sir, Manoharan sir, Sunil Joshi sir, I think that is the message should go, I think, to them. Robin?
Yes.
FNAC of the lymph node, you have told why? Shubham or Apurva?
So if the lymph node is palpable clinically, either at the popliteal lymph nodes or any kind of lymph nodes at the groin are palpable, the first investigation we send out is the FNAC of the lymph node to confirm any kind of micrometastasis or anything of that sort.
FNAC is negative.
Sir, if the FNAC is negative and if the lymph nodes are still clinically palpable, we can go for sentinel lymph node biopsy.
No. Lymph node, sentinel node biopsy is done when?
When you will do sentinel lymph node
biopsy? Indication for sentinel node biopsy is very specific. No?
When the lymph nodes are palpable, will you do the lymph node sentinel lymph node biopsy?
No, sir. Generally, if it's not palpable, then we go for sentinel lymph node biopsy.
If you are not able to detect the lymph node, you search for the sentinel node. Which are the conditions you use sentinel lymph node procedure? Which are the conditions?
Sir, if we are considering breast cancer or penile cancer or malignant melanoma, these three conditions are.
Three conditions.
Yes, sir.
So FNAC of lymph node, if it is negative also, still you have to be a little cautious. Okay. Then That is why sentinel node topic we came. Then CECT of chest and abdomen is for metastatic control.
Yes, sir.
Why PET CT?
This is the question mark. Because now, sir, problem is now most of the oncologists advise PET CT for everybody.
What a question mark. Question mark.
Well, sorry, actual fact.
Again, you put C. SLNB, sentinel node biopsy with the question mark. Here, this case, it is indicated or not indicated?
Sir, not indicated because we are able to palpate the lymph nodes.
So why you put it and put a question mark in it?
Sir, the reason why we included because other than breast.
You're asking, sir, whether to do or not to do.
So, if there were any complaints of any sort of cough, breathlessness, or hemoptysis,
So
then we could
CCT chest, you have done CCT chest now. Why do you want PET CT then?
So if there are any sort of evidence of metastasis to the lung, then to rule out any other metastasis to liver, brain,
You
or
have done,
any
you
kind.
have done CCT of abdomen.
Clinically and treatment-wise, what difference it makes? Already patient has got CT and then just symptoms. Additional findings you are going to pick up. It is already metastatic disease.
So ideally, what is the ideal indication for PET CT in melanoma? There are people now doing PET CT for every patient asks for. Patient straight away says, I want to get PET CT done, then you are helpless. You can't say guideline is like that. Otherwise, what is ideal? You will say this patient, you have to undergo PET CT. An indication, probably depth of the lesion after excision biopsy. If depth is, I think, Robin, I think, Sir, Sunil Joshi said, depth of the, if
Yes.
depth more than 4 millimeter, then they will indicate it as a PET CT. Tumor markers already share, they have highlighted, is very mainly useful for prognostic value and eventual follow-up actually. So important, no incision biopsy, excision biopsy, sir, I told very clearly. Probably ultrasound guided definition can do. PET CT, depending on the depth, otherwise easy chest and abdomen. SLMB when it is not palpable, but discussion will come into the picture when you present a melanoma. So need to know about it. Some tumor markers names you should know actually for melanoma. So we'll go. Sunil Joshi sir will go to treatment.
Sorry, I think once you have an excision biopsy and you have depth assessment and the lateral spread as well, that gives you the most information that you need. And practically, that is the one thing that we are looking at. And of course, yes, lymph nodes if they're palpable, if not SLNP, I would agree with that. Investigations are all okay. Tumor markers, I'm not sure. We usually don't get an opportunity to do this.
Mainly depth, this one, biopsy and depth, and this one. So next slide.
Is Apurva going to say something about the depth, some histopathology levels or classification? Do you have any idea and you want to enlighten us?
So, sir, there's one classification, Clark's classification, and there's another Breslau's thickness classification based on Breslau's thickness. So, if I talk about the Clark's, then it is invasion. Like the first class is when it is in the epidermis, it involves the epidermis. Then the second one is when it extends into the papillary dermis. But the third one is when it completely invades the papillary dermis, and the fourth one is when it invades into the reticulate dermis, and the fifth one is when it invades further into the subcutaneous tissues.
This is Clark's. Yeah.
Yes. And based on the Breslau's thickness, it's basically class 1 is when the thickness is less than 0.75 centimeters. Then the second grade is 0.75 to 1.5 centimeters. The third one is 1.5 to 4, and the last one is 4.
Excellent. Excellent. Can you tell me where these melanocytes are situated in the dermis? Are they in the epidermis or dermis?
So
in the
it's in
basal
the
layer.
it's in the basal layer of epidermis.
Epidermis. Okay. Okay. All right. So when it is limited to epidermis, it has the best prognosis. It can only spread laterally, and the
Yes.
prognosis depends on the depth.
The depth.
Most important. Okay.
That's
All right. Good.
most important. That's why Breslau's grading is more crucial. So you said block dissection. Sunil sir, they are told written block dissection.
Sir, block excision. Oh, okay.
Inguinal block dissection here, they have written treatment part.
Yes.
Why you wanted to do this? What Shubham and Apurva, why not do block dissection?
So, since the lymph nodes are palpable in this case, the lymph nodes are clinically palpable. So, we would do a resection of the lymph nodes from the ileoinguinal area.
Okay, that's Robin. You want to ask anything about this?
Wide local excision, the management. I just want to ask, is there any sort of procedure that you can do which is also diagnostic and treatment at the same time?
Some procedure which is both diagnostic and treatment.
No frozen section.
No frozen section.
What do you call the procedure?
You can give some clue. Start with some word, some letter you can tell. Start with M or something like that. You can tell.
Microscopically oriented histographic surgery.
Renaissance.
Okay.
More surgery, micrographic surgery. Okay, so you involve the pathologist and the surgery, so you get to know the levels and the margins. Okay. The indications for lymph node block dissection, as Sir was asking, inguinal, is for clearance?
When you will you do prophylactic or only therapeutic, there is a controversy. Of course. When you will do add on the prophylactic, when you do only therapeutic, when you confirm it, it is there. When it is not there, we'll go with the SLNB. When it is not there, will you remove it or not? Sometimes it becomes prophylactic. So we'll go ahead with that.
Yes. Adjuvant therapy, what you want to do?
Sir, if it has metastatized to the liver or the lung, then we'll go for chemotherapy. And even after surgery, chemotherapy is advised. Other than that, we can go for radiotherapy if a brain and bones are involved. And we can also do biochemotherapy, which is using chemotherapy as well as interleukins and interferons.
Yeah, those are new ones. Yeah, okay. Yeah.
No. Robin sir is asking, this patient adjuvant therapy, are you going to give or not? Because we presume that CT is normal, lymph node probably not. You have done the dissection, you have done the wide local excision.
Do you want
Sir,
for this patient?
since chemotherapy is indicated even after surgery, so we will give him chemotherapy.
What drug?
Sir, there are different drugs, like there is a CVD regimen, which is cisplatin, vinblastine, and dicarbazine. Other than that, another one which is very famous is DICT, which is diethyl triamine carboxyamide. So even that is used for chemotherapy. Melphalan is phenylalanine mustard, that is also used.
So that is the in this probably that's what. So Sunil, anything else to ask them, and then we will go to the next slide. Then I'll have a small brief afterwards. My slides I'll put into that.
Okay. So, yeah, I think that's fairly, they've covered it very well. I'm okay with this to proceed to the next slide, please.
Okay. Before that, I think they should have known the differential diagnosis, like Sunil, you wrote lightly. They should keep their mind widely. Differential diagnosis, they should remember.
Think of the simple things first.
And examination, opposite limb, I don't know whether they have mentioned or not. Unlikely, but need to mention opposite limb. And other systems, they have already mentioned brain, lungs, systemic, Fred, everything. ABCD discussed, Clark's, other gradings to discuss. So I think just go to the what has happened to this patient. It's our unit patient. Next slide. Then I'll put the slide. Next slide. We did the wide excision because biopsy already was done somewhere else. with the clearance. Ideally, should have frozen section which we have here. Otherwise, Manoharan Sir, like rightly told, you should have a frozen section to see the depth. That's why we didn't cover the defect. We kept it like that until biopsy report comes. Of course, my assistant wanted to do a dissection also because we are not sure. Next slide. So we did the inguinal dissection because iliac lymph nodes were not palpable. So with the restaurant angle, we did an inguinal dissection. This one again, biopsy report had to come. Next slide. I think these people were there. These both Apurva and Shobham were there while doing this procedure. We did the inguinal dissection with the thing. So Sunil, just how they presented your opinion, frank opinion about their presentation. Then I'll go through my slides, few slides. And Robin, definitely, sir. Manohar sir, anyway, is there to give the. Sunil?
So that's an excellent dissection that I can see there. All the lymphatic and fatty tissue has all come out well. And what vein is that? Students there?
So the great saphenous vein.
No, that is removed. What is visible there? Artery and vein.
Femoral artery and
the femoral vein is also visible there.
And the sartorius was rotated over that.
Sartorius was rotated, and we can also see adductor longus muscle also is there.
What is the need to cover the sartorius muscle there?
To cover the exposed femoral triangle and the vessels and the nerves of the femoral triangle.
Okay. Shubham and Apurva did a very excellent presentation, sir. Really, very hats off to them for undergraduate knowledge.
They did well, actually.
Narration and the way they faced the questions. My best wishes and congrats both Shubham and Apurva. Very good.
Robin, thank you so much, sir.
Both presented well. They were bold. That is that. And this is definitely a case will be kept in the exam. They should have the idea. Differential diagnosis. Skin carcinomas are not uncommon. Remember, commonest malignancies are skin cancers. This is the commonest malignancy. Okay. I'll just go through my Robin. Just you tell your opinion about the students. Meantime, and go through.
Shubham and Apurva, it's a very good presentation. Yes, you are floored by your presentation. A few corrections. That's all. Chief complaints are fine. Your history of present illness, again, please don't mix up your pain with your lesion. That's why Sunil sir had caught you there. So be very specific with your lesion. When you come to examination, this is usually kept as a short case probably. And please be specific about your colors and all that. All your symmetry and everything. You've answered all the questions, but be very specific there. Next. And your diagnosis. I don't think I've ever seen anyone saying a 56-year-old person with a black discoloration ulceroproliferative lesion on the right plantar. This goes on like Mahabharata. No, the diagnosis is what? Right foot malignant melanoma staging. That's it.
All those you are told in the summary.
That's all. Summary you have done well, but you don't have to put a diagnosis. Second, differential diagnosis. Very important short case because you need at least two relevant to your case. See, that's because you have mentioned all this. We were forced to ask you everything about pigmented BCC, pigmented because site of the lesion, is it common? No. Sir has asked you something about even at the lesion, the trophic ulcers. It's a very valid question. Trophic ulcers are very common in that spot, especially when you give us something about the pain also. So always please be very specific.
For 2 years.
Two is enough, but very relevant to your case. Otherwise, it's perfectly fine. Yeah, both of you have done very.
Sometimes the lesion will be the interdigital clips. You have to search after knowing the secondary. You have to search for the primary. That is how usually the
problem. And many times in trophic ulcer, necrotic material looks like that.
Looks like flat.
It's a very valid point. Professor Sunil Joshi had told actually.
Robert sir told. Remember that you have to examine the entire mucocutaneous junctions, especially the perineum. Melanoma always you have to screen the mucocutaneous junctions. Very prone for
they presented well, Robin. You are the examiner. I am the internal, so I have to take my voice. But yes. You should tell. But to go, they presented well in online.
Apparently, Sir Shubham and Apurva are having a lot of fans on YouTube.
Is it okay? Well, that is nice. So, yeah, Robin, I'll just go through my slides just to
Yes, sir. Sure,
Yes,
sir.
sir. Please.
uh, this swell. Swell is just surgical anatomy. You have to know. My line diagram I have drawn, epidermis, dermis, different types of glands, all those things. And skin adnexal meaning you should know. Skin adnexal tumor, many times a differential diagnosis for all these cutaneous malignancy. Adnexa means hair follicle, sebaceous gland, sweat gland. And nail comes, of course, here, other part it is not. So, sebaceous gland, hair follicle, sweat glands clubbed together as a skin adnexal tumor. One of the differential diagnoses you have to think of. It may not be in this situation, otherwise, in many other situations, when skin lesions are there, you have to think of more, maybe rare, but many times it will be. Next slide. Then again, I put different gland, different. There's a Merkel cell carcinoma can occur, receptor. Very aggressive malignancy, rare. Luckily, it is rare. It straight away goes for spread actually. Next slide. So epidermis, all those different types of layers are there. You have to remember these layers. Even the epidermis is thinner than the dermis, because mainly epidermis, it's avascular, but it's very, very important. Keratinocyte, melanocyte, Merkel cell, stratum basal. The basal layer is important for melanoma. No basal cells are there, so that's why that's important. The layers. Next slide. So all these granulosome, spinosome, there's a Malpighian layer. There's a word called Malpighian layer. That's a combination of basal and spinosome together called as Malpighian layer. Many times, many MCQs I saw actually was with Malpighian layer, which contains. You remember, basal and spinosome together called as Malpighian layer of the skin. Next slide. Lucidum mainly the soul and hand, not in other areas. Thick actually. What is the protein it contains? The L-idine protein. Again, that is the MCQ. I've seen many MCQs. This question has come. That's why I put into that. Next slide. So this UV rays are very, very important in the skin malignancy. Many skin lesions are related to the ultraviolet rays. So you should have a small idea about the UV rays, mainly ultraviolet B rays. That's why I put this slide. What is the wavelength, frequency? Slowly you can go through and understand this subject. But if you understand, you will have the clear idea. Why ultraviolet rays are very, very important for all skin disease, including skin malignancies. That is the main causative agent actually. Next slide. So this is the UV ray. What is the visible? 400 to 700 wavelength? It is visible. UV A, B, C is not visible. Mainly, what we are concerned with the UVB between 315 to 250 wavelength. Because why I put it is it's a very common MCQ asked in your NEET or competitive exam, but it's very relevant for pathogenesis of the many skin diseases. Next slide. So again, I put reverse A for wavelength, B, C. So what we are concerned, especially these conditions, with the UVB. Next slide. So skin tumors again, epidermal, dermal, benign, malignant, melanocytic, skin adnexal tumor. Others like sarcoma, angiosarcoma, T cell lymphoma. These are the different skin tumors which you have to remember. Next slide. Skin cancer again, the current classification is melanotic and non-melanotic classification. Even the non-melanotic is very common. Which is classified because melanotic is very, very aggressive. They have a systemic threat. BCC is only locally malignant, and SCC is local regional malignant. So commonest malignancy in the skin is rodentals or BCC, remember, but its classification is melanotic and non-melanotic. Next slide. I'm not going to detail it. The current WHO classification to the 18th, this one, keratinocytic, melanocytic, skin appendageal scheme, whatever I've mentioned, little detail they have given actually. Next slide. Again, same thing, apocrine glands. It's very difficult to remember all those names. Just nutshell, you can remember that skin adnexal tumor. But again, important is soft tissue tumors in the skin can occur. Now, dermatofibrosarcoma, earlier it was classified as a skin tumor, malignant skin tumor. Now, this classification shifted to the soft tissue sarcoma in the 2018 actually. But many times we put it in the skin tumor and soft tissue sarcoma. So, inherited syndromes are very common. Familial melanoma, Grolin syndrome, skin cancer, xeroderma pigmentosa, you are told actually. New Torres syndrome, all those syndromes is mainly important for you for MCQ purpose. Otherwise, we also can't recollect these things in a point of time. Next slide. Etiology, remember UVB rays. This is very, very important. What is UVB rays? These are the different etiologies for skin cancers, including melanoma. All those syndromes also I have mentioned here. Next slide. So nevus, again, we are discussing what is nevus, pigment relation, different types I have told. how it happens. Melanoblast is the precursor cell actually. Again, UVB rays is required for melanin synthesis from the basal layer. Remember, so it is important. What is name versus pigment? You can see that next slide. So again, this is the different types of, remember, this is the different type. What is important is there are so many moles are there. Maybe useful for MCQ, but our purpose, dermal, compound, junctional, juvenile, congenital, these are the important names which we have to remember. Next slide. So congenital, I said giant nevus more than 20 centimeters. It's very important because it is a pre-malignant condition. And otherwise 1% of the body surface area. Next slide. So intradermal, there's what Robin has asked, intradermal or junctional. What is the difference? There's a difference between junctional is the most junctional is the potentially malignant condition. Remember again. So next slide. Compound nevus, both combination intradermal and junctional again. Why it is junctional, you have to remember. Blue nevus, Mongolian spot, all those things probably you are learned in the pediatrics, common in children. Next slide. So juvenile nevus is a misnomer. Juvenile melanoma is not melanoma, it is a misnomer. Juvenile nevus. Again, there are subtype, Fidget nevus, Hutchinson freckle. All those things are MCQ questions, just to go through that. Hello, that's what Robin hello, depigmentation around the pigmented nevus. Why this hello is important? What is the reason for that? Next slide. Hello, maybe around malignant melanoma also. Remember, next slide. Next. So again, I'm not going to discuss these things. Names of aorta, aorta, all that in the related mention. If you remember, after MCQ, remember familial melanoma in syndrome, it runs in family. So wherein the family is very important. Next slide. Because dermoscope is there. In many pigmented, many thin lesions, dermoscope is available. You can see it properly. So exactly you can assess the clinical all list. That's for dermatoscopy or all dermatologists have this kind of dermoscopy. It is magnified view of the lesion. If you do that, then you will have the proper idea, proper identification, proper assessment of the lesion using dermatoscope. So all this excision bias is very important. So that excision bias marker when you do that. Ideally, sir told margin clear excision biopsy with the frozen section actually. Next slide. So melanoma, I'm not going to detail this. All these things are important mainly because common in this area, Australia, Auckland, because UVB rays are in more in those areas because of some reason in the ozone levels in the universe. Next slide. So UV rays is important cause. 90% of causes of the UV rays actually. It's common in the white skin. This is the xeroderma pigmentosa of exactly looks like typical look of the excision repair is defective there. So next slide. All those chromosomes, you remember that is exam MCQ they will ask. It is difficult to recollect. You can always read the book. Next slide. So genetics also very important plays role. I'm not going to detail it. All these MAPK, GOA, BRAF. I mean, all means it is very, very useful. These are the genetics which is very useful in melanoma. Next slide. So clinical types, this is important. Good old metatype, superficial spreading, most common, nodular melanoma, lentigomelanoma, acral lentiginous melanoma, and A melanoma is rare, but it doesn't have pigmentation because it is dedifferentiated, though no melanin production. So the worst type actually, it looks like, see that looks like a software sarcoma it is. Other types are ocular melanoma, Robin has told already, because there are no lymphatics inside, so lymph node spread is not common. But a late liver spread is very common. We have got a patient, we had patient who has removed eyes after 10-15 years, it comes with the liver enlargement. So late liver enlargement, late secondaries are very, very common, especially in ocular type. Next slide. So AML, I already told it is uncommon, but difficult to identify, no pigmentation. Again, ocular melanoma, this patient had undergone eyeball removal and he came to our unit with the large liver. It turned out to be liver secondary. Next slide. So this is the class already discussed actually, and Apurva has answered. Class grading, this breast close grading is very important. 1, 2, 3, 4. Based on thickness, node spread. See that thicker the lesion, more the nodal spread. This percentage wise. Next slide. So I am not going to discuss features. So again, satellite nodule we have discussed there. Intrinsic nodule we have discussed. The permeation, embolus, everything happens. So pigmentation, ulceration, bleeding, itching, halo around the ulcer. You are not either you have mentioned or not induration. There is no induration. Have you mentioned in the palpation no induration?
Yes, sir, we mentioned.
Most important, unlike squamous cell carcinoma, there is no induration. Very important clinical finding in melanoma. There is a point which you have to remember. Next slide. So blood spread. See that this is the intransit nodules in a patient. This is the satellite nodule within that. This patient has come 2 days back to my clinic. They had some other traditional treatment, and later they confirmed melanoma with the PET CT showed spread elsewhere in the body, all over. The typical when they came with this intransit nodule, just a few days back they came to my clinic. It is a metastatic disease all over. This is the typical intransit nodule. This is the satellite nodule. All this blood spread, you already you are told bone, why liver, melanuria is another dark colored urine. When there is a liver involvement occurs, melanuria occurs. It says that if there is a dark colored urine, that means it's a metastatic disease. Clinical, you can say. So always ask the color of the urine, especially if you feel think that there is a threat. Next slide. So ABCD again we have discussed. Robinson has already discussed asymmetry, border irregularity. All those post of marine sign, all those signs are important for MCQs. I can't recollect. Color is important. Diameter is important. Evolving. That's also discussed. Progressively changing in the most size. This ugly duckling sign, ugly ducking sign, ugly ducking sign. Again, many times I have seen asking after in the MCQ. That's why it is important. A, B, C, D, E. This is important. It's in why also they will ask in clinical side when there is a melanoma kept in the case. Always they will ask what is the full detail about A, B, C, D, E. Remember, sometimes ugly ducking sign, all these post of many sign. Next slide. The feature Glasgow criteria you already discussed. Shubham has answered that. Glasgow criteria major and minor. Other changes again we have discussed melanoma in situ, staging, crusting, bleeding, itching, nodularity, ulcer, satellite lesion. Next slide. I'm just nutshell I'm putting what we have discussed. Again, no incision biopsy, excision biopsy at the primary 2 millimeters are told 1 millimeter beyond that. That's what he said. Punch by scan may large only. Otherwise, your answer is excision biopsy. Don't deviate from that. No incision biopsy, excision biopsy. Ultrasound of the nodal area and FNAC, SLMD, we have discussed that. Chest X-ray and ultrasound, it currently CT, chest, head, and this one. PET CT when it is depth is important. And all these markers, mainly what we do is LDH, it is available. All these things are in oncology setup, but only thing is other markers are costly. So in a given patient, especially in a government setup, whether we'll be able to do it or not is a question. Next slide. So this is a staging which you have to remember. Mainly we are told that what the staging means. I'm not going to detail it. You can always read book. Next slide. So these are the differences. And again, we have discussed pigmented which is not in the soul. In other area, remember, not in the soul, we won't tell. I have put the generalized the places. Okay. Kaposi sarcoma, hemangioma, skin adnexal tumor, maybe a different type. Solar keratosis, pyogenic granuloma, angiosarcoma, soft tissue sarcoma, especially amelanotic melanoma mimics soft tissue sarcoma. It's a different thing. You have to remember. Next slide. The treatment is wide localization. The word wide is very, very important, not just local. Depth margin, both clearance is important, confirmed by the frozen section biopsy. In the criteria, but handle is wide localization in both areas. In research, small in the name required for amputation, toe, finger, and so on. Enucleation, I forgot the word. Enucleation of the eye may be required if it is involved. Next slide. And lymph node already we are told FNAC, FN mobile lymph node, therapeutic node section, fixed lymph node only chemotherapy, maybe downstage and do, but that point of time, usually it's metastatic. Prophylactic, there's a controversy. I'm not going to decide about it. Prophylactic dissection I will do in melanoma or not. In commercial carcinoma will not do it, but some people they do depending on the depth of the lesion. They may decide about prophylactic lymph node dissection. Unknown primary do the dissection because many times remember, especially in the anal canal, in the external genitalia, may not be able small lesion. Primary is very small. They presented the metastatic disease or lymph node involvement. Such a situation may not be able to identify the lesion. Then go ahead with the dissection. Then do adjuvant therapy. Next slide. So these are the things: lymph perfusion, infusion. There is a difference as I already mentioned. Perfusion with oxygenator, infusion without oxygenator. So these are the drugs which you have told. Targeted therapy, endolymphatic therapy. Next slide. So prognostic factor, thickness, mainly thickness, most important thickness, then nodal spread. All those things are vascular innervation, mitotic index, vertical growth, intraproduce, staging, younger age, female estimated regression. So the follow-up how to do always in this patient during LDHNG, ultrasound, and so on. PET CT maybe they currently they do PET CT. Next slide. So that is about melanoma. The nutshell what I have put actually. I think I request everybody to subscribe my YouTube channel. All students who are view this one daily lectures, daily MCQs comes in the YouTube channel. Last 1 year, almost near 1 year, it is happening. So go through that, learn surgery in a brief or in 5 minutes daily. You can go through that and learn surgery. And my books are known to entity. Robin, I spoke it in a very briefly, sir. Manoharan sir. Anything to add? You can always tell Robin. And already it is one and a half hours.
Yes.
And I thank Professor Sunil Joshi Sadal because he had some meeting. He left very much because he agreed and from Chikaballapura Medical Institute.
So, some questions are in the chat box, sir.
Okay, sir.
People have asked, we have put questions in the chat box.
Okay, it is here, I think.
After the session, at least it will.
Yeah, select here to sign what is that? How to get it? Hey, Robin, you can go through the question chat box.
So not in this. In YouTube, I've asked many questions, but they haven't.
Not in this link, sir, probably in the YouTube link. Not in this link, maybe the people have messaged that some professors are on the line.
I just check the questions. That's in the YouTube, I think.
I'm looking at the YouTube, but I'm not able to find any.
Anything to find here. So before you just check, sir. Before concluding, I thank presenter Apurva and Shubham. They presented very well. Really hopeful because others also will present eventually. Other students, it will be encouragement for them.
Thank you so much, sir.
Very nice.
Thank you, sir.
Yes. I thank Professor Sunil Joshi for joining with us, and he made all his students to join also. I thank my dear friend Robin. Shukriya, very nice. Thank you very much. Always he's with me, sir. Manoharan sir, always. Whatever time is there, exam, he'll join, sir. Even from different place from his home, he is to join. Very much grateful to sir. Robin, very much grateful to you because without you, it's difficult.
Listening to you and learning from you, sir.
But it is. I also learn a lot from you because
again from Robin.
I can't think of my live session without you, both of you, sir. Yes. Robin and Manoharan, sir. So next, Robin, I don't know next session. Professor Sunil is present.
Yes, sir. If they are there next week or after Easter, I think here in Kerala always
timings. And after that, your students once they're ready, you can go with the different discussions. You can get.
You guys are writing the exam in June, July?
Huh?
Next year, sir. Yeah,
no, next year.
June.
So
next January, they are writing their final year.
We will come there as
a ones are not rise with present.
Come and sit in the examination and ask you. Nice.
Okay, sir.
Miracle is one.
I want to come again to Mangalore. I want to try the chicken curry again.
Okay, come. When you come, you have to come to my house also. But I
yes, definitely.
Other day he has come to my house actually. That is that. So questions anyway. I will answer one line later. I think.
Yes, sir.
I thank you very much. Already I apologize. Initially, there is some hurdle with the network. But they immediately tackled my IT people. Of course, I was a little upset. I was upset about that. But immediately, within 2-3 minutes, they could tackle the problem. I'm very thankful to Aditya and others. They do very well, even though a little stress I had initially because I have some problem with the PPT uploading. I apologize for the 5 minutes delay for that, but it went on well. I thank you, both of you, sir, Sunil Joshi, sir, Manoharan, Robin. Thanks to all students who have joined the YouTube channel. It's available daily anyway. You can always join, go through this one whenever they need it. Again, thanks very much to Shubham and Apurva. They presented very well. Good applause to them. And Robin, sir, good night very much.
Good night, guys. Yes. Good night, sir.
Thank you, sir. Thank you again, sir.
Bangalore.
Thank you so much, sir. Thank you.
Thank you. Thank you, Robin. Thank you, sir.
Good night, sir. Good night.
Good night.